Thank you everybody for coming. I very much appreciate it. I'll try to stand out here and talk. I'm kind of more of a pacer than I am stand behind the podium and talk. And if there's any questions as I go through, please stick up your hand and I'll try to answer them to the best that I can. But I very much appreciate you guys coming out. As I walk through, kind of explain who I am, what the department is, where we are as a department, and then some of the procedures that we're doing. And then at the tail end, kind of talk to you about some other additional procedures that not necessarily are being brought into house, but we're going to kind of expand. And it's an exciting time in the hospital. So first, what I'd like you to do is to introduce you guys to the Department of Radiology and who we have. We're now a team of 6. Starting at the top, that's Dr. Cutts, Jennifer Cutts. She's in the back, and thank you for attending. You can see where she's coming from in her training and fellowship in both musculoskeletal and breast, and really brings a lot to the table. She's also our chief medical officer and the department chief. So has a very full boat. Mary Hockman on the right, University of Pennsylvania. But I guess the fellowship and really her specialty of what she brings in is MRI in general, broad, all encompassing, and then specifically MSK as well. Dr. Richard Gray down there in the left-hand corner has got quite the pedigree, as you can see. He's a neuroradiologist, fellowship trained, also does an extensive amount of interventional work, kind of like me as well. I just minus the neuroradiology. On the right-hand side, that's Dr. O'Brien. He's a Unicom grad, just like I am, and his fellowship train is cross-sectional and body. He's kind of like the department encyclopedia. If you have a question about radiology, 99% of the time, he can answer the question. So it's always good to have one of those folks in the department. That's Charlie on the right, duplicate, sorry. And this Danielle, Dr. Layton, literally is just joining us. She started, I met her for the first time today, just before I was coming over. Very pleasant. Interventional radiologist. She is a vein specialist, really is working more. There's kind of 2 sections of interventional radiology. There's the vascular side, and then there's kind of everything else, right? She does everything else, but is really good at the venous, the venous side, and was a director of vein care in her last facility in Minnesota, I believe. So just met her, absolutely fantastic, and now we've got a full team. Not to bore you too much, but this is me. Was born in Portland, Maine. Went to Boston University, then I'm a graduate from Unicom, just like Charlie. I'm an Army doc, so I did my internship in Madigan Army Medical Center in Tacoma, Washington. I did my residency there as well. Part of the military plan is once they pay for you to go to medical school and then pay for your residency, you owe them 4 years. So I wound up in South Carolina, which was a shock to everybody. And we ended up staying there an additional 6 years. I will leave it at that. The South was an interesting place to be, especially. I will keep. Anyways, it was an interesting place to be. I loved it. Great people. I'm a diagnostic radiologist, and I've always had great interest in interventional procedures, and so that's also what I'm bringing to the table. So it's nice because now we've got Dr. Gray, we've got Danielle who's coming in, and myself, and all of us will be kind of cross-filling for interventional radiology, really allowing us to build a robust program. So, why you guys came here today. So what is a compression fracture? So first off, let's talk about why we get them, right? So there's a principle, and it's either abnormal force on normal bone, right, or normal force on abnormal bone. So something gives, right? So something gives. And what we typically see is a normal force on abnormal bone, right? That is kind of the definition of osteoporotic fractures, insufficiency fractures. And the way we get them is frequently I've had folks come in and they said, I sneezed really hard and it collapses. Or quite frequently somebody said, I have no idea what happened. I think it might have been when I was getting out of bed the other day when I just kind of fell on my knee. So that's the common. The abnormal, as far as kyphoplasty is concerned and vertebral augmentation, we don't do a lot in the acute setting. most of those folks, it really is it's a division, and we'll talk about when do we intervene? When is this a good tool to apply? And then we also, for neoplasms, for painful neoplasm, we don't do that frequently, but it is something that we can do. Now, it is not treating the neoplasm, it's treating the symptoms of having a metastasis or a primary bone lesion in the spine. So the vast majority of these occur in the thoracic and lumbar spine, and that's just where our weight is and where a large portion of our dynamic motion is. So it kind of makes sense. And what you'll see frequently in vertebral compression fractures is that people, and this is the dangerous part, people will get okay in one position, and they don't want to move because that position is okay. Any movement really kind of spikes the pain up and does it quite dramatically. And we'll talk about that as we go along. So osteoporosis, and we've got a specialist here with us as well, so she can chime in whenever she'd like. On the left-hand side, there's the trabecular matrix, and it really is kind of just think about chicken wire going in all these different types of direction. It creates like a central strut within the bones, right? And it kind of gives you the ability to distribute forces, like shear forces, as it moves, right? So it's not just simply a bone getting compressed in one direction. It allows it to move and transmit forces in a number of different directions. It also does create the compressive ability, the ability to withstand axial compression. Axial compression is like that. So normal bone on the left-hand side. On the right-hand side is just massive demineralization. And you can see not only are the little septa, the tiny little walls, thinned, but they're more sparse. Right? Then you see these big type of cavities in there on the left-hand side. Got to point off to here. Oh, that didn't work. Is this a laser pointer? It doesn't matter. I'll point. So you can see on your right-hand side, just inherently weak, inherently deficient, a setup for potential problems. So the and this is one of the things that we do routinely, DEXA scans, and I'm not sure if anybody has had a DEXA scan, but we monitor folks. We put them into a category of normal, osteopenia, osteoporosis, and then we kind of monitor as far as the treatment and is there the appropriate response to treatment. And then folks will adjust their treatment based on how the bone density is doing as a result of their treatment. So moderate osteoporosis, and then we get into, and you can see the gradation from the top all the way down to the bottom, where those little spaces, these kind of like little vacuole spaces, just become larger. The trabecula become thinner, and you're setting yourself up for problems. Can everybody hear me? Is that okay? All right. Okay, so the demographics, and this is always stunning to me, just how prevalent it is. And we see, having come from the South, now the South, which is really interesting, is we're the belt of a number of different things, and it's like the vascular disease belt, renal arterial disease, renal failure, diabetes, they all kind of go together. Up here, I have seen, and just been anecdotally, I've seen a lot more demineralization in this population than I do down south. Perhaps it's the seasonal variability. Perhaps it's less vitamin D exposure or a stimulation from the sun. But I've seen a lot more. And that's just anecdotally. I don't have numbers for you, but I'm saying in my reports, worsening osteopenia, a lot. So 10 million Americans have osteoporosis. These are just kind of numbers, and some of them are wow numbers. The next level down, so osteoporosis is the most demineralized. Osteopenia is kind of between normal and osteoporosis. The 700 vertebral compression fractures annually within the United States, and that's my little kind of asterisk to the side, probably about a third, maybe less than what we're actually diagnosing. Because I would say, because the number of spine studies that I see where they have old compression fractures, I don't know. We don't have prior imaging on them to say, oh, they were aware of this. My assumption, as well as a number of other folks' assumptions, is that it's about a third of what we're actually getting. So probably 2.1 million or more that are going around. 50% of them women, 25% men will have in their lifetime one fracture. Problem with that is that you get one, and this is what I was talking about before. You want to stay nice and still because it's movement dependent, and all of a sudden you start that downward spiral because you don't want to move. Your body needs stimulation in order to continue building and remain plastic. So 5 times greater, 1 vertebral fracture per second worldwide. And it is roughly, this is always the hard part, $17 billion is what it costs the United States. It's probably a lot more on an annual basis. So this is what I call the stasis decline. And it follows, sorry to any of the physicists out there, but my interpretation of the first law. Body in motion will remain in motion. And that certainly is the case with general health. The body likes to move. And it's one of the things we've seen routinely, it's a part of medical training, is that stasis, right, things not moving, is not a good place. And you can see it with airway breathing. You can't take a full breath in. The chance of pneumonia goes up. You stay still, your risk for coagulation and clots go up. Your urinary system doesn't work, your risk for infections and stones go up. The body does not like to sit still. And that's a huge part of what medicine does, is really try to get people better so that they can start moving again, right? So these are just some other stats. So with 2 days in bed, there's actually a statistical decrease in bone mass. 1 week in bed, 50 times greater bone loss than the person if you took 2 people at the same time, put in rest. This person, bone density who's moving will be 50 times greater, or this person will be 50 times less. That's how substantial it is. And then in the end, after 10 days, this is amazing to me. 10 days in bed rest is the equivalent of 10 years of muscle loss. Now, I'm not sure how many of you folks have had surgery. I had really major surgery a while back, probably like 10 years ago. And I was down for a period of time. And I was amazed at how much muscle loss that I lost. And I was 40, you know. So, and then as we age, we're losing our muscle mass anyways. We're losing mineralization. So you really want to kind of keep what you got. And that's the whole idea of vertebral augmentation, is to get the folks back into life, get them kind of active again. So treatment alternatives, and this is a good kind of bifurcation, right? So we are not talking about, this is why I mentioned the traumatic compression fractures. We're not talking about the vertebral compression fracture. Yeah, it kind of hurts, but I can get by with Tylenol, or I can get by with other stronger type of pain medication. This is, I can't move. You know, this is, I don't want to move, because every time I move, it's miserable. Treatment options for that is kind of like what I had talked about before. So physical therapy in that, absolutely fantastic. But as far as getting people out of the woods, you know, and into healing, very challenging, very challenging. The bracing, the open surgery, so then the problem with open surgical fixation becomes the bone's weak, right? So you can't really go in and use its neighbors to buttress it to fix that level because they're weak. And if the patient has been down for about 10 days, then those bones are weaker. And so it gets into this vicious cycle. That's what they call this downward spiral. So back pain, fracture, hunched over, respiratory reserve goes down, your lungs, you're not taking the same amount of deep breaths. Talk to you, the body doesn't like stasis, increased risk for pneumonia. And you can see it just spirals down, loss of appetite, sleeping problems, as everybody can imagine, decreased activity, more bone loss, increased fracture risk, and it just plummets. So that's what we're trying to get people as quickly out and back to normal life as possible. So imaging evaluations, that is also, you know, obviously within the Department of Radiology, we pick up a lot of these on plain film. I'll tell you, a number of folks will come in and they'll say, oh, I just got this kind of pain. And I always tell patients, the body is not mapped perfectly for pain. Sometimes you'll get a fracture somewhere and it's telling, you know, it's like presenting itself in a completely different place. And so frequently we'll have patients who will come in and they'll have some type of chest pain and we'll image it and they'll have a compression fracture. Frequently, I will have patients come in and they're looking for a pulmonary embolism. because it's this pain which to a physician looks like it's a PE, a pulmonary embolism. And they'll get a CT of the chest to look for PE, and we see compression fractures. I see it all the time. So we start with plain films. If I'm still kind of guessing, right, we'll go to CT. CT kind of, I'm like, I'm not really sure if that's new or old. We'll get a CT, and I can look for secondary signs. CT is still not enough for me to plan what I'm going to do. I need MR. And the reason that I need MRI, I can get by with bone scan as well. On the very far aspect, and this is gonna, why I kind of showed you the pictures of the vertebra. On the very far right, that's a certain type of sequence. And as you can see, on the far right, there's like a white tube, right? There's a white column kind of going up, and then there's a gray band on the inside. That white column on the outside is cerebral spinal fluid, just fluid. Let's just consider it to be tap water, right? The body is so predictable with injury. You know, I punch you here, it's going to get swollen, right? I slap you there, cut you there, and I cut here, it's going to get swollen. The body responds, one of its mechanisms is to get swollen. It increases blood supply, capillaries become leaky, fluid leaks into the area. That's how the body starts to respond to start the repairing process. So it allows me in that where this arrow is right here to say, wow, there's fluid in there. Because that white looks like the white next door to it in this cerebral spinal fluid. So there's fluid in there. And there's other things we can do to kind of confirm that, but that's pretty straightforward. So number one, that tells me that it's acute. So I can say, yeah, this is kind of referable, if it's referable to that level. Sometimes it's not. But what it helps me a lot with is it's going to tell me that bone is going to be kind of spongy. So not only is it good because it's telling me that's where the pain is, getting into it becomes much easier. The bone is much softer, right? And that kind of goes along the whole idea. Why are you putting cement in somebody's back? All of that kind of comes together. We have pain, we have osteoporosis, so it's decreased overall strength. We have edema in there, it's spongy, right? And all of that, you get this kind of instability. And one of the thoughts is vertebral augmentation is kind of the big catch-all, right? One of the thoughts is that the concrete that we use is extremely thermogenic. You put it in there and it just starts blasting heat as it goes through the chemical process to start forming. One of the theories is those nerve endings in that vertebra are so raw, and they're just like, it's just like having like a road rash, and it's just every time you touch it, like, oh my gosh, So the idea is that heat burns those nerve endings. We don't know. But it makes sense because people will come out from the procedure and be completely symptom-free. But that's important. If I can't get that on you because for some reason there's a contraindication you getting an MRI, I'll get a bone scan. And bone scan kind of tells me the same thing, kind of. It's not perfect. I wouldn't want to always have that. I can get by with that. So this is kind of one of the parts of what we came from. Vertebral augmentation brought to the States in 1993, was in Europe before. I was talking to some folks before. The first person who did this, I tip my hat to them. It would take a tremendous amount of courage. I'm not sure I have that courage to start something like this, and some out-of-the-box thinking. Remarkable. So number one, right, is kind of trying to show you in there those little trabecular, remember I was talking about chicken wire, right? So there is some osteoporosis. That vertebra on the backhand side, let me see if I can get sorry. Aha. So this is the vertebral body right there. This is a pedicle. Basically what this is a junction between the posterior elements, kind of a little bridge to the front. That's good because we're going to use that as our highway to get in and out. Right? So normally, vertebrae are near perfectly square. So this one has got a wedge on the coming down. So basically, the top surface has kind of compressed. It makes sense, right? If you're looking at the vertebra posteriorly, you've got all this extra support system. right? You've got pedicles, and you've got a number of other different bones, and you can just see it. So the place where it fractures almost all the time is anteriorly here. And so it just squishes down. Okay. So what we do is we use this pedicle. How about that? I already lost it. So we use this pedicle, and I can show you a little bit more detail. And we put a tube in through the pedicle with the patient on their stomach, cleaned up, fully anesthetized, and we pass a tube into there. We pass a drill in, not like it's like an old school drill. It's not like, I'm hooking up to electricity. This is me turning it and pulling it out. I'd like to have absolute control, and I try to stay away from any of the electrical devices. So go in and basically make a hollow little chamber, right? So I'm allowing, then the next thing that I'm going to do is I'm going to pass in my balloon, right? And so it is a kind of like a tubular balloon, extremely high strength, distributes force equally all the way across, and very, very puncture resistant. Because you can imagine inside those trabecula that I showed, imagine if you kind of cut chicken wire and all those small spikes are sitting off to the side. Very, high risk for puncture. So we go in, and we'll talk about this a little bit more. Go in, put a balloon in. This is when we start revving up on the outside, and we put what's called methyl methacrylate. There's other agents, but it's a polymer, very thermogenic, as I said, and we will fill the cavity. The idea of the balloon dilatation, they just used to put concrete in. They've had greater success. The idea is maybe we'll restore a little bit of height by kind of blowing it up. Not necessarily. People can say they do. I don't really see it that much. More, you're creating a larger cavity. So it allows you to put it in, what my experience, you put it into this cavity, and then it starts to leak out a little bit. And so you really kind of get a controlled distribution. And we're doing this on both sides of the patient. We're kind of going 1, 2, 1, 2, 1, 2, put the cement in, and we're done. So moving on. Anybody have any questions? Okay, so there's a kind of a larger blown up version, the internal cast. Those are the balloons that we use. This is an actual procedure, so we kind of come in on the patient's back off to, we call an oblique approach. There's two different types of balloons we can use. We can use the straight balloons. Basically, we bring them both into the center of the vertebra. We're talking about the anterior, that block in the front, so that they're kissing together, and then allows us to distribute equally on both sides. That's one of the techniques we can use. Another one is this, which is a single approach. And you're getting into one side, and it's got a curved balloon. Actually got a curved introducer and then a curved balloon. So it comes in and it kind of looks like that. And it goes all the way to the other side. I use those for a very specific purpose. When a patient's vertebral collapse is really significant, I'll use it to get into the smaller side. So I know I couldn't get two balloons in both sides. So I'll basically get into the bigger side and then try to get as much over to the smaller side, which is collapsed, more than the other side. So that's kind of when I use it. I don't use it routinely. There are some people. I like the fill and I like the results that I get from doing the bilateral approach. This is, here is actually an example of the procedure, right? It doesn't really project that well, I'm sorry. But this is the balloon going up, and then this is the cement coming in. Patient's already had one level treated below. Patient benefits. So this is where things are just amazing, right? And this, my favorite story is the hospital that I was in, South Carolina. There was a lady, and she was in the moderate to severe back pain, completely, just couldn't move at all. She was going from her bed to her Barcalounger, bed to Barcalounger, and the pain control was really only when she was still. No matter what she took, whenever she got up, it was debilitating pain. So she came in. They tried, conservative management for about 7 to 10 days. And they sent her over to us for a consultation. We said, absolutely, we can get this taken care of. And I try to get people in as quick as possible, right? Because I'm battling against that spiral. That's the way that I look at it. Plus, if I can help somebody not take them out of pain, that's my goal, right? So we treated her, I think we got consulted on Monday. We treated her on Thursday. No, we treated her, consulted Monday, treated her on Wednesday. It's an outpatient procedure. You come in and you go home, and the instructions are, go live your life, get up and walk around. You don't need to go, and like any additional follow-up with some caveats, and I'll explain that. So I follow up on the patients the next day. Ring, 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 ring. The phone is just ringing and ringing, and she didn't have a cell phone. And so, the nurse starts to get a little bit worried. Then I start to get worried because she brings it to my attention. So we call that night, and we call the next day, next morning. And now I'm like, oh, do we need to send the sheriff over there? So finally, around 2:30 on a Friday afternoon, the phone answers. She answers, and they're like, oh, Mrs. So-and-so. She said, oh, in her nice southern drawl, said, I'm doing perfectly fine. I had chores that I needed to catch up on. I've been laying down for a while. She was in out, and she had absolutely no pain. That's not everybody's case, but the dramatic drop in pain afterwards is almost universal, right? In my experience, the folks that we've dealt with. So that was amazing. I lost a couple nights of sleep on that one. But this is really that is emblematic and encompasses everything that we're talking about, that one patient. Significant pain relief, increased range of motion, return to previous level of activity, quality of life, and it goes on, and it goes on, and it goes on. And all of this has been studied under tremendous amount of scientific scrutiny, and it holds up every single time. The one thing that's not necessarily that some people tout, does it restore height? Maybe not. Does it make people better? Absolutely. And does it get them back into their life? No question. Does it take them out of that spiral? Sure. I mean, without any doubt. So, this is crazy, right? This is the next step of what people are considering. Very isolated, but truly a jack, right? It's limited in how you can go in, because these have got to be, on the receiving side, the vertebrae have got to be big. And you can see as we're kind of designed, vertebrae get bigger as you go down. Right? And that's just because I was talking about in the beginning with the axial loading. You just need more substance as you go down. So these, you can get into the big vertebra, kind of L1 all the way down, and you get in and you crank them up, and they open up inside the patient's vertebra. They restore height. There's no question about that. And then you put the concrete in, and you're done. Remarkable, because we are now getting a jack through a hole that's smaller than this. So they're starting the training. It just and there's a lot of there's questions about it. Not something that we currently offer. Kyphoplasty is something that we offer, and it's tried and true. Seen it work and be effective routinely. So this just amazes me. Let's see. And other things that we'll be kind of talking about in the future as well, we're adding prostate MRI. It's kind of screening, but we're going to be adding it as one of the services here. We'll be working in tandem with urology. It's really super exciting. We're adding new agents for looking at people who have had prostate cancer so that we can follow them and see if there's any recurrence. That's kind of new to the market. They've got more sensitive studies which are coming out. Probably we'll be getting them at the end of this year. Another specific type of agent. We'll be getting those. Let's think. And ablation as well. So percutaneous, minimally invasive tumor ablation as an option for treatment instead of open surgery or surveillance. So that's kind of all what we're doing. Can I answer any questions? Yes, ma'am.
I'd like to ask you about, you said there's long-term studies. Could you explain any of those long-term studies and where one could find?
Yes, sure. The name of the study is called EVOLVE, E-V-O-L-V-E, and it's a multi-center study. And what they've done is not what I meant to say, if I said long-term, that's not what I meant is multi-center, deep dive into the statistics. If you look,
1993 when they first
so basically there's a little bit of an interesting history with kyphoplasty and vertebroplasty. It first came out, and in the orthopedic literature, they did a study. Sham study, not real, intervention study. They showed that there was no statistical difference. Subsequently, people have analyzed that study, and they've looked at some of the people that they included in that study. Some of the people they included in that study were compression fractures that were like 10 months old. What are you going to do? You know what I mean? That's not really, maybe there's some other surrounding structure that have been damaged. Maybe it's muscular injury. So they didn't really get the right group. Subsequently, they've gone, and this Evolve study really kind of covers everything. And that long list of patient benefits is what it comes out. So if you look at patient pain, it drops. If you look at patients' return to function, it increases. And they use all the appropriate testing. It's a remarkable study.
And I can just look under Evolve if I Google it.
If you put in kyphoplasty Evolve, you will get a ton of information. Very well done study. Sure, please.
Could you discuss the material? You said acrylic or?
It's a polymer. I can tell you kind of what I know about it. I actually wanted to, sorry, I brought props and I didn't distribute them. But I will give this to you and you can pass it around. This is what it ends up as. That's actually from a procedure that we did in 2018. That's what it ends up as. It truly is rock solid.
Under any, I guess I would wonder if you could think of a piece of hard candy under certain conditions, it won't be hard candy, but this obviously.
There's no temperature that you can expose it to.
And it's polymer, and does it have any other names?
It's called methyl methacrylate, and I can get methyl methacrylate, meth acrylate. Is that right?
You look
Like
at
acrylic?
PMMA, kyphoplasty.
Yeah, PMMA. They do have some other, they've got some other agents that folks are using. That's what we're using. That's what I've had a tremendous amount of success with.
So these agents, obviously, when you're doing these long-term studies, I'm not sure exactly, I guess I'd have to look it up to see how many years, but it also would mention if there's any problems with the material.
Oh, yes.
Had a bad reaction or.
Right.
some other-
I have not read any, there's the complications that, so the complications involved, so this is always part of the deal, right? Anything from the outside world to the inside world, violating skin, bleeding, infection. No way around it, always a risk. There's always a risk in here that the concrete goes where you don't want it to go, right? So it can kind of extrude. There's always the risk because you're going by the canal to get in. There's always a risk that you can get into the canal, right? There's a lot of vital structures around it. That's surgery, that's medicine. There's, but that's part of it. The other big risk that people have, and this has been, is that folks, I don't know which specialty they were in, but they were very aggressive in doing multiple levels. Like at once, like 8 levels. Concrete got into the vasculature and gave them concrete pulmonary emboli. Now, as a result of that, right, it is unheard of to do more than 3 levels at a time. I don't like doing more than 2 levels at a time. Now, two is just perfect for me. Because then I can say, okay, we can treat these levels. Did it help? Did we get the ones that we needed to get? So those are the basic risks. The other risk is more compression fractures, right? So that's the risk. But if you look at the risk of subsequent vertebral compression fractures, and that was the slide, that was about 24%, non-treated patients will get a vertebral compression fracture, right? And that makes sense. You're kind of in that place. 13% of people who have had kyphoplasty will get a vertebral compression fracture, again. And it kind of makes sense, right? Because you've altered the mechanics of the body. load distribution has changed. And so people are at greater risk because you've already osteopenic. Now you're kind of forcing the bone to go through structural changes, and they can become weak. You know, that's kind of why I say when you've been treated, I don't want people to be doing jumping jacks and kind of, you know, running on the stairs or anything like that, but I want you to move. I want you to get your body going again. And people will have, where I had the needles in, there will be pain in the muscles that I went through. But otherwise, you should go.
Is there any tie-in with, a number of us are on some type of medication, or we've had some kind of treatment for osteoporosis. Has there been any tie-in with this procedure? And say something like, I can't think of it, reclass, or a lot of treatments, medicine.
No, because we're kind of coming in, you know, we're coming in at the very tail end. You know, that's most of the folks that we're treating. They're already, like some of the folks who have come in are profoundly osteoporotic.
Okay, so.
You know, so my job is to get them back out, and then hopefully then they can address that a little bit more with the osteoporosis.
Before they come to you sort of before, sort of in a more acute setting.
That's
or
right.
Anything, 'cause
They come to me miserable, you know, and I think that if we get them back, yes, sir.
Is this something that is directed towards osteoporosis only? Or are there other problems with the vertebrae?
The vast majority is osteoporosis. We'll use it.
It almost sounds like it's a substitute for what might have been called a fusion.
It's another alternative, you know, because if there is an isolated fracture, and I leave that specifically to the orthopedists and to the neurosurgeons who specialize in that, if there's an isolated level, right, which has a vertebral compression fracture, it's not always easy to find healthy anchors to go above and below the injured level, because everything's kind of weak around there. And as an organism, right, this is always the problem. The body's trying to tell you, we were having a conversation earlier, the body's trying to tell you that you've got a problem. And your body collapses around that area to get the most amount of protection possible. I see it routinely. So people come in, if it's a lumbar, you know, they're not moving their lumbar spine at all. So those areas surrounding it will be very weak. Sometimes it's hard to get into them. I have seen folks go in and do the compressions, go in and do the kyphoplasty, and then go in and get surgically stabilized. So I've seen that. So kind of working in tandem. Does that make sense?
Yeah, the reason I asked that, back in 2002, I had a laminectomy, and it was a question as to whether or not I might have a fusion at the same time or whatever, and it was evidently not necessary. And everything was fine for about 5-6 years, and then all of a sudden, it seemed like either arthritis was coming back in revenge, and you know, so now I can stand up straight, but as soon as I start walking, I'll bend over. And if another person asks me to stand up straight, I'm going to punch them in the mouth.
Won't get it from me. Even though I'm a military doc,
I don't know if this is an option, because I had no reason why I was coming here today.
Well, I appreciate you coming.
I attended all the things that one could say when you came for the lunch, and I know the rest of it do. And I didn't know you were going to be talking about this here. I thought it was going to be other kinds of fractures in other parts of the body. I couldn't understand all the terminology. But, you know, look at it. Gee, this is very interesting to me. And I don't know if it's something that could help me or not in that circumstance.
It's got a very specific application. It really does. And we're talking about compression fractures. In there, you know, insufficiency, right? Insufficiency fractures. So we also call them pathologic fractures when you have a tumor in there. It's weak. It's weak because there's infiltrate, there's tumor cells in there, or just because it's osteoporotic. So under the big umbrella of back pain, what it sounds like you're talking about, it would be different. So you've got facets, you know, tons of articulation, you've got exiting nerve roots, you've got a number of different things which can cause it. So this is really kind of isolated to a specific patient population, you know, and not good for kind of beyond that is not really that helpful. Ma'am.
Is there a window of opportunity that after they have the fracture, that the kyphoplasty works the best, and then when they're outside the window, that it may not.
Yes, what I've found, again, a lot of this stuff is just kind of anecdotal. And if you go back to the original MRI that I showed you with all the kind of, fluffy water in it, as that starts to go down, as that fluid is just kind of, again, it's like the body is very, very predictable. As that fluid starts to go away, that means we're in a different type of reparative phase. The bone actually starts to become stronger, and you're laying down new, new bony matrix and new mineralization. It becomes harder for me to get in because it becomes more sclerotic, more dense. So, yes, in the first 2 weeks, when it's really swollen, that's when it does the best. It really comes go through. Now, I will say that I've seen some on the very tail end, and the fracture didn't completely heal, and it's almost like a sandwich, right? So you have a fracture above, fracture below, and then you've got all this tissue in between, which is we call granulation tissue, and it's really irritated. And so I've gotten into those before and just kind of spread a little concrete in there just to burn those nerve cells, and people have had great responses. That's not the primary goal to go in, but I've gotten in before just to say, listen, let's see if we can help, and it actually helped. But that's not the primary use of it. Does it make sense?
And I have a second question.
Sure.
After the procedure's done, are there any precautions for the patient in terms of lifting, bending, any immediate precautions?
I always tell people don't pick up anything really heavier than a phone book. I just like to kind of take it easy. I don't want people lifting up laundry baskets or changing tires. But what I really want, and I tell everybody, is so yes, to a degree, but I want them moving. I want them turning. I want to kind of get them out of this linear kind of positioning in motion. So, a number of folks, one lady asked me, can I make my bed? I'm like, yeah, sure. Don't go jumping on it, but just, kind of move around gingerly. But that's what I want. I want people to start moving. Sometimes a little hard, too, because the muscles will be irritated where I went in. But we put in a long-acting lidocaine to kind of tell the body, quiet, get back to work. Sure. Anybody else? Yes,
Can you
ma'am.
talk about the age of any of the people that you
All over the place. We've done 90-year-olds. We've done, I've done early 50s. The lady that we did down in Columbia who was in the early 50s. So really, that's the majority of our population is kind of like from 50 up. But if somebody has, for some other reason, some type of congenital issue or has profound osteopenia and they get it, right? Or they're just on tremendous amount of bed rest for some other skeletal deformity and they get it, they're certainly perfect candidates. Well, I want to thank you guys for coming out. I really do appreciate it. And hope we'll see you next time.